long words that don't mean much. But really, I want to focus in on a few cases and what we might learn from some of these cases. And I also want to speak to what we do within the criminal justice system, because there are some overlaps, and that's where I find myself working a lot of, and trying to explain to people some challenges that can happen for certain individuals. And I can say that in the work that I do, it's fascinating. I don't get called to a police conference to have this conversation, which is weird, right? We think that that's where I should go, because they're the ones intersecting a lot with certain populations. And so if they had this level of understanding, I think that would be very powerful and very beneficial. I've yet to receive that, and so maybe one day. I want for people here to understand how complex this area is. I've been asked to talk more about like substance abuse, things like cannabis abuse, so we'll talk a little bit about that. And I want to really speak to what comes with things like FASD, what can come, not for everyone, but for some people, and how we go about treating that, because we want to make sure that we do a really good job of identifying all the different challenges and then providing the right interventions for those challenges. We can't just sort of do things. I apologize for the slides, there's lots of data and numbers, but that's just, again, that language that I come from, that world that I come from. These are my real objectives that I want for you all to get. I want to start to rethink treatment that doesn't just focus on getting a diagnosis. I know service cannabis here. It's interesting to me because oftentimes to get services you need to have a diagnosis or a label, and then it becomes everything that someone is, and that's not the way that it should be. This is one part of a person, and in my opinion, resources should be allocated to not so much based on do I get this diagnosis or not. And that applies to autism as well. And it's very challenging, I think, for lots of youth, lots of family, lots of young people to navigate these very complex systems. So I'm thankful for the presence today. I imagine they're here to help as well. I want to really then focus upon interventions to help young people and their families. And what I'd like to do is really plan and think about that future ahead of us where FASD is really identified quickly, if present, but more so thinking about what do we need to make sure that gets treated here and how can we help. So, to start, I've been asked to focus a lot on FASD because I understand that's what's on the conference, but also I know autism is discussed, so happy to take questions there as well. I think I'm going to try to get through as many of these slides as quickly as possible to get to the Q&A section, but I want to bring this slide up because we need to think about how common this is. And in the world, it's probably less than 1% they think. And we don't really know these numbers. We're sort of guessing, so it's a really big guess. Then we looked at Canada, and we thought, oh, maybe it's just 0.1% of the general population. In 2019, 5 years later, well, no, it's probably 4% of the population at least. So that's a big change, right? And that means that we're starting to understand that this is much more prevalent than we would have thought. Then if we look at children who enter into child welfare systems, so what we call the Children's Aid Society in Toronto, there's many different names, and we're quite fortunate in Toronto to have separate Indigenous First Nations child care program. But when we look at youth who enter that, in Manitoba, for instance, it can be 13 times the rate of the general population. 13 times it. So more children in care potentially have this diagnosis. When we look at adult criminal centers or justice centers, we go into jails, 1 in 5 almost are thought to have FASD. If you think about these numbers, they're staggering. And it means that we're probably not doing the best job at bringing a lot of attention and knowledge to what is actually happening here. A diagnosis that is found in potentially 4 out of 100 people, that's actually 2 times more common than autism spectrum disorder. Yet, when I typed it into ChatGPT to try to figure this out, which was quite interesting to me, I asked it to calculate how much money gets spent on a child or a youth per year across the country. And then I asked it to do the same for FASD. The best it could come up with after reviewing, I don't know how many resources it does, but really it's probably half that gets spent in the world of FASD on a child. We think about diagnoses like cerebral palsy, Down syndrome, even Tourette's syndrome, much more common than those symptoms. Yet, those symptoms are those symptoms get more attention from our healthcare system and from how we go about providing treatment. So how many clinics are set up, There used to be a Tourette's syndrome clinic where I work. Yet, there's never been an FASD clinic where I work, but it's 40 times more prevalent. So why is that? Why does that happen? I think it's a good question to be asked. So when we think about FASD, I think it's good to really get on the same page about what we know about this diagnosis. So what we know is that when the brain of a developing embryo in the mother's body is exposed to alcohol, alcohol, unfortunately, is one of the most difficult or challenging chemicals that can impact a developing fetus, specifically its brain. So, when you've got a brain that's forming, it's covered by a barrier. A lot of you might know this. And that barrier is meant to keep out a lot of chemicals, a lot of toxins that would impact the brain. Alcohol is the one chemical that's really small, and it can get through that blood-brain barrier quite easily. And when it does, it actually goes into where the neurons are forming, and it stops them from forming. So all that brain development that is supposed to happen, the connections that are supposed to happen in a certain way, they don't, because the alcohol comes in and it actually stops it. So as your brain is developing outwards, it gets trimmed in some ways, where the connections don't happen in the right way. And depending on how much alcohol there is, the time of development and when that ingestion occurs, so when that person actually has had the drink and when it affects the baby, that can have different impacts on how that brain develops. Various brain structures can be impacted. The chemicals that make up our emotions, how we feel, the systems that make those chemicals can also be impacted. So if we impact things like serotonin, production centers, that can change how we might feel sad. Then we add in, well, some of the children, like for instance, I told you about children in care, they're going to experience so much more trauma, I would say. And I can speak to that, and people can challenge me about it if they'd like, but I would say, I would put my license on it to say that there is more trauma in children raised in care than not. And if anyone wants to disagree with me, please by all means put your hand up. We can have a comment. I'll change the nature of this talk entirely, but I'll try not to. But I would say that when we add in all that trauma, well then that impacts how the brain's going to develop as well. I think what we're starting to understand is when you create an environment where there is a lot of trauma, potentially, and you already have that sort of development process that is different for the brain, then we're going to see more challenging outcomes as a consequence of that. So when we combine the two together, I think that's when we have reason to be a little bit more concerned. And that leads to why there is higher prevalence of certain kinds of mental illness in individuals who do meet criteria for a diagnosis of FASD. When we look at things like substance abuse is 21 times more common in individuals with FASD than in the general population. How on earth? 21 times, just imagine that for a moment. If you were to take a room of 100 people, and there was only one person in that room that had substance abuse challenges, then you took people who met criteria for FASD and put them in a room, and there were 100 of them. 21 of those would have substance abuse challenges. That's the kind of difference. And that's what we know of. Again, we're not good at keeping track of any data. No matter what government agency might try to tell you that we do a really good job, we actually don't. We thought it was 0.1%, and 5 years later we think it's 4%. That's a huge difference, right? How on earth can we make that kind of mistake? How on earth is it that even at 0.1% we're like, wait, we need funding, we need to actually focus on this. Well, now we're at 4%. That was last year. I haven't seen, maybe I've missed them. I haven't seen very many announcements about how we're going to be able to bring the right resources to bear. So just a thought to throw out there. ADHD, that is a specific condition, attention deficit hyperactivity disorder. It has to do with how the front of the brain operates. It has to do with dopamine levels. Well, when there's an imbalance and there's an inability to focus attention, there's an inability to really think certain decisions through, maybe be more impulsive is what we call it. So you sort of do something really quickly without thinking about all the consequences. That's 10 times out of the general population. That's a big difference. So alcohol use also goes up, conduct disorder, which is probably why I work as a forensic psychiatrist. Most of the kids I see are conduct disorder youth, and that is 10 times out of the general population, so that's what the population I do. So I told you there'd be numbers, and I apologize, but again, this is from the language I speak, it seems, and we need to always back up what we say. So here backs up what I say. It's 10 times more ADHD, don't worry about the specifics, but there are other diagnoses there that are also more common. So we ran into some problems in Toronto when it came to working with children in care. And we were like, I worked at the CAS, I still work there as a consultant psychiatrist, and that's our Children's Aid Society of Toronto. It's the oldest CAS child welfare organization in Canada. And there's quite a few children. But what we noticed is that we'd always identify these kids. We thought, I think FASD is here, but we don't know how to go about getting anything done in that regard. Like, where do we go to get a diagnosis? Where do we go to do this? And when we do want to get a diagnosis, we have to refer to a specialty clinic. It would take 2 years to get an assessment done. And we would get this very long report, nicely describe what sort of problem there is, but very little in regards to what we would do thereafter. What do we do with this information? Now that we know this youth has FASD, what does that actually do for us? And so we started to make a few changes, and we, in 2016, decided, let's just do this ourselves, and we'll deal with it afterwards. We started doing the diagnosis in-house. So we started to identify which youth had FASD. We did our own measurements, and we did a psychiatric assessment to decide if they had the criteria that are set up in Canada. And we made our own diagnosis. What we focused on was, what else do they present with? So not just, do you have this diagnosis? Because what does that really change? We want to focus more on, what does that mean for you? Does it actually lead to certain challenges? Okay, I think this works. If not, I'll just talk really loud. I don't think it does work. Okay. So we started looking at how it is that we can identify what other illnesses they have, and then make the system, that CAS system, start focusing on what you're going to do with these children that present differently and that have these challenges. And there were lots of barriers before we were able to do this, to sort of diagnose FASD in children who were in care. And some of the challenges are here. Obviously, it can be difficult to confirm alcohol consumption in pregnancy, lots of complexity, multiple environment changes. All these factors led to significant challenges even being able to get that diagnosis done. So doing it at the outset was our way of doing things. And in that world that I told you about, where we speak that sort of language, we tend to write things down, we send them out to the world, and only if others, experts in the world, say that what you've done is rigorous enough, it makes sense, it's backed by science, do they actually publish it? And so here's an article that we wrote on identifying FASD and psychiatric comorbidity in the community through that kind of approach. Not having to go to a specialty clinic, but instead doing it with a pediatrician, a child psychiatrist, and then bringing that diagnosis to bear for her. We did it through 3 phases. We actually had our CAS workers, so social workers, complete a screen at first. It was called a neurobehavioral screen. And then they were seen by the pediatrician to look for certain physical findings, because that can happen. And then there was a psychiatric assessment done that didn't just focus on whether or not there was FASD, but more so focused on what are the other diagnoses that can exist here, and what do we need to do to treat them. Here's a sample of the neurobehavioral screen. I think it's 10 questions, they're very simple, yes, no. The pediatric assessment, I mentioned sometimes there are facial features associated with FASD. That was part of it, also making sure the heart and the lungs were okay. Height, growth, other elements were also looked at, and whether or not there was any history of confirmed alcohol ingestion in pregnancy. And then, because with the psychiatric element that we were able to do, we looked at what are other diagnoses that are present, and what treatments should we put in place. That might include medications, it might not. But what about psychotherapy? What about behavioral therapy? What about putting in place the right resources, school resources? How do we set this youth up for success? But more so, we focused on what kind of home are they going to live in? A kid with FASD is not going to do well in a home with 7 other foster children. They're going to need a lot of one-on-one care. So can we identify that? Can we educate foster care workers that this is why we want for you to care for this child and really not have other children in the home? Can we set up these kinds of resources? And so that was something that we started to focus in on. When we looked at 18 youth, that's that N number, that went through this process, we actually found that 100% of them met criteria for ADHD. Other diagnoses were also present, including learning disabilities, tic disorders, conduct disorder. We tend to switch classes. Then in 2022, we looked at another 25 patients that came through a similar kind of process in between the age of 4 to 17. And we found almost all of them were coming. This was a different kind of clinic that wasn't directly in CASE, it was a separate one in the community. And most had been adopted, actually. Only about half of that, or just over half, had confirmed prenatal alcohol exposure to alcohol. And we were actually able to look at what we could find out regarding that alcohol timing, so when that consumption occurred. And we also found that there were other substances abused as well. And this is when we actually get that information. It doesn't always happen. What was interesting is that in those youth that were diagnosed with conduct disorder, almost all of them had engaged in fighting with other people and property damage. There was a higher incidence of animal harm than I would have suspected, and stealing. So before they came into this clinic, they came with, some of them came with diagnoses, so about half of them had been diagnosed with ADHD. 1/3 got a diagnosis of autism as well. When they were done, that actually jumped up quite a bit, so the ADHD went quite high. We actually only diagnosed comorbid autism, so autism being present as well in just 5 cases. But as you can see that after the assessment, the number of diagnoses also increases. So getting that assessment done early on in the process, looking at comorbid illness, can actually assist identifying all the challenges that that young person is going to have. When they were seen, almost all of them were told about potential new medication options that would exist. Or if they were on other medications, then the dose needed to be changed. So that was part of the recommendation. Most got psychotherapeutic recommendations. There was also an opportunity to say, you know, something else might be happening here. Maybe we need to get genetic testing done. Maybe we need to get a neuro consult done. Maybe we need an EEG because there's seizures here. So we want to make sure that we identify these things. So really, what's needed? We need greater awareness and consideration of FASD as a potential diagnosis when a child is presenting with other illnesses. So when we have youth come to clinics or come into systems of care, come into youth justice settings, we need to start to say, wait, if they have like 5 or 7 diagnoses, has anyone even asked the question about FASD? And if not, why not? If it's 4 in 100, we think, at least that, maybe we need to start asking that question more often. We need to have greater access to specialized assessment services, but more so that are focused on treatment. And of course, it would be helpful if we knew what we were doing, because I think sometimes we feel like we're operating in a black box. We're just all trying to do what we can. We have no real good data. It's starting to be collected. I know Canada FASD, maybe members here, I think we're doing excellent work at trying to gather this data and bring some coherence to that. But why focus on that comorbid illness? And I hope I've made my case. And really, when you start to identify all those things that are troubling that young person and start to treat them, you can improve outcomes for early intervention, you can reduce other problems that can happen, you can improve their outcomes in terms of how they function, and we can actually refer them into the right places. Quickly, I'll go through a case study. This is based on a real case. So a 10-year-old girl was in foster care with 5 other children. The biological parents had separated when they were 2. Both parents had abused different substances. The biological mother had initially denied alcohol ingestion, but the father, of course, came forward and said, no, I saw it all the time. The child had multiple learning and developmental concerns, lots of language delays, hyperactive. They had certain facial features that we thought were consistent with FASD, and they were really getting into a lot of fights, and were really targeting some of the siblings. So there was 5 other kids. There was biting, punching, and kicking, so very challenging. Came to the clinic, we actually found that they had this central facial features, met criteria for FASD, but also met criteria for ADHD and ODD. They got treatment recommendations put in place to target those symptoms. Sleep was a challenge as well, so we were able to target that. There's something at CAS that's done, is something called a complex case review, and that happens where certain youth get extra attention around where they're going to live, what kinds of supports need to be put in place. So we were able to do that. At the age of 12, they stabilized and they were suitable to be adopted. And they had some very specialized services, medication management, with a pediatrician that was able to follow them. They don't need to have a psychiatrist forever. I don't need, my goal is to not have a job. It'd be lovely if I was worked out of existence. And so it's nice to be able to see kids get taken care of by pediatricians in the community who feel like, you know what, I know what I'm doing. I think I can help here. This is what I needed to have. So just a few clinical things to keep in mind. ADHD is often comorbid. Sometimes when you treat for ADHD, you actually treat for oppositionality. I'll go through another one really quickly. A 17-year-old boy was charged with assault caused bodily harm. Very little contact with the family. The mother indicated that they had drank alcohol in the first trimester. Schizophrenia was quite prevalent in the family, with dad having that diagnosis as well. Lots of challenges, learning disabilities, challenges at schools, multiple expulsions, but a very heavy use of cannabis at the age of 17. And at the age of around 15, they started to hear voices that was often associated with them being really high. So smoking a lot of weed caused them to get these voices. And started to develop a belief that other people might harm them. And so they ended up really acting on that belief, on these voices that were telling them, look, this person's going to harm you, you better get back fast. And what really became evident is this young man had FASD, but also substance-induced psychosis. And what we've come to know is that if that young person has FASD, they might be more prone to the development of these other illnesses, like psychosis, like the bad things that happen when someone smokes a lot of weed, and that can lead to paranoia. A lot of youth with FASD and ADHD are quite impulsive, and so there can be this increased involvement with the criminal justice system. There's also something called false reporting, and we're prone to sort of saying what an investigator wants to hear. So it's like, oh, you think I did that? Okay, yeah, I did that. And it's actually been found to be quite concerning. There are multiple cases where someone had met criteria for FASD, no one really talked about it, no one found out about it, no one diagnosed it. And when seen by police, they're confessing to even murders that they hadn't committed because they just come up with the information. Something that can happen. Lots of different interventions have been put in place in Toronto. I won't go through these, but I do want to focus on a few things regarding forensics. I think I'm okay for time. So I'll go through this really quick, but when youth face charges, they used to live in Vancouver, and we had this amazing idea there, which we haven't done here in Toronto, but if you had a diagnosis of FASD, you were taught to carry a card that you would pull out whenever the police would arrest you. And I clearly said, don't ask me questions without my lawyer here or my parent here. This is their contact information. I've been diagnosed with a condition that can cause me to give you a false report. And I'm prone to telling you that I did something even though I didn't do it. And just having that card and for that youth to be able to pull that out and say, these are my support people, please read this. We don't have that here. I'd like to see it one day. I don't know if I'm the right person to do that though. I think all of you are the right people because I think our youth, and having worked in different youth justice settings, it really is disappointing, I would say, to see how many youth go through without getting the kinds of intervention that they need. Sometimes when you face charges, we also have to ask them questions about whether or not they know what's going on in the report. And in cases of autism, and in some cases of FASD, they might not have the wherewithal to know what's happening, right? So I don't know what a judge does. I don't know what my lawyer's job is compared to the defense lawyer. How am I supposed to know that? Like, that's not something that I'm going to understand. And so we ask them certain questions to decide if they're what's called fit to stand trial. If they're unfit to stand trial, they should not go through the legal process. Oftentimes, you need someone to do that assessment, and that would be a forensic psychiatrist. Sometimes we're asked to comment on whether or not someone's criminally responsible. Someone can be so unwell that they don't understand the nature of right versus wrong, and that's where they're found what's called NCRD. Quite rare within FASD, but it can happen, and I've been involved in a few cases as well. They might not understand that moral or legal wrongfulness. They have to have disease in their mind present. They have to appreciate the nature of the act, or they weren't able to, and could they exercise a rational choice? Those are some of the things that we ask. In young offenders, we often think about NCR when there's cases of psychosis present. So could they actually understand right from wrong? That thing that I told you about some youth with FASD kind of saying whatever the person wants to hear, it's something called confabulation. It's like lying, just sort of making stuff up. I think sometimes I'm really good at it. I'm not doing that today. I hope I see there's something so it's meant to be real. And then there's another part in the youth justice world that lets us do a full assessment of a youth. And this is kind of sad as well, because you have to almost commit a crime, get arrested, be charged, and then the Crown Attorney or the defense attorney need to say, hold on, I want to get a really good assessment done, which includes a psychiatric assessment potentially, also a psychological. That's called a Section 34. You can ask for that, and that can then lead to a diagnosis if you have the right assessors. In Toronto, we're working on something called Justice Centers. I'm really proud of this project, so I'll speak very briefly to it. But it involves taking a focus and a different perspective regarding primarily Indigenous and Black populations that are overrepresented within the criminal justice system in Toronto in certain areas. And so the entire youth justice program there has been broken up to say, we're not going to focus on what's going to happen to you after the fact. The moment you're arrested, we're going to start thinking about what you need to be better. And so how do we identify what you need to be that successful adult that we want you to be, and how do we do that? And so we looked at how do we ask that question, what do we do? We found that if we ask questions in these separate domains, like health, housing, food and income security, employment, education, resilience, psychological empowerment, that we can better understand how you get to a successful transition. So we developed a tool called the STAT tool, Successful Transitions Assessment Tool, and it lets us ask questions in those 8 domains, and the young person actually just fills out a very easy survey of 21 questions or 30 questions. That sort of just helps us find out where they are. So I'm going to come back to my objectives, and hopefully we'll have some time for questions if there are any. But really, these were the 3 things that I started with, which are more of that scientific thing. What I wanted to do was start to rethink treatment and not just diagnosis, focus upon interventions that help young people and their families, and plan for a future where FASD is readily identified, and so is comorbid illness. I think what I want you to take from everything I just said is there's so much more work to be done, and I think we can agree with that. And I think we can also agree that unless we have the right kinds of resources, the right cultural informed programs, that we're not going to really do due justice and due diligence to this population. We want to be able to ensure that they understand that having a diagnosis of FASD might also mean that they're more prone to other forms of mental illness, and so how do we make sure that they get the right treatment for that? And not to feel shame or guilt about it, but just to understand that the brain functions differently. And so if they've also been exposed to more trauma early on, more challenges early on, well, that makes it more difficult altogether, and so that can be really challenging as well. So I'll open it to questions. I'm hoping there'll be some questions, but I really just want to focus on the fact that what I presented here, it's really some perspectives, having worked in this area for 10 years, and I don't know why, nor do I want to claim to know it all. But I'll do my best to answer questions.
I Dr. Patel.
Just Mitesh.
Very happy to talk. A lot of what you're talking about is being mirrored by Dr. David Gilbert, University of Salford. And I was wondering if you had any workings with him. Because he's currently working on an FASD justice program right now, talking about how we can be railroaded.
Yes.
You don't understand the system. I was wondering if you had any thoughts on that.
I actually looked that first up. I take it they're in the United States.
University of Salford?
I think that's
UK.
Oh, in the UK. All right, maybe then I'll definitely look him up. But I do think it is a good thing to start to collaborate with other places. I would say, certain places, I would say that our experience in Canada is very, very different from that of the UK. The fact that this impacts certain populations much more than others is definitely something to focus on. But that justice center idea that I told you about, it's actually based on British models as well.
It's an international study.
Oh,
It's not UK-based. In fact, I take part in it myself. Because a lot of what you're talking about are the same things that he's working on.
great. And that's excellent. I'll have to look that up. Maybe I'll get the name for you afterwards. But there are more people doing good work out there, which is excellent. And thank you for your work. It's RJ. Yes. So very important to have that work done, especially given that if it's 4% at least of the population here in Canada, I think there's a lot more work needs to be done on the advocacy side. Any other questions?
I have a question. It's kind of a question, or maybe it's two parts, but so knowing the variety and scope of symptoms and things that are involved in FASD diagnosis, which include like physical and different things like that, who's to say or why, and also knowing that a lot of people don't get an FASD diagnosis before they have the alphabet soup diagnosis, who's to say these other diagnoses aren't just a component of the FASD? Or are we doing it just because you're looking at it like an access to you? Like, is that the purpose? Like, what's the purpose of that? And you know what I mean? Like,
Yeah,
who's to say the
totally.
symptoms of ADHD aren't just part of having FASD, and knowing that in FASD, it depends when the consumption of the alcohol happen, so you can have everything, it would affect all those things. You know what I mean? Like, so there's no, I don't understand, because it's almost sort of seems like going backwards when someone gets 10 different diagnoses and then we're like, oh, they have FASD, now the other ones, don't they just go away? Or what's the point of adding?
Yeah, that's such a good question. I really like that question. I think, and I think of another one. So I'm going to ask this one first, if that's okay, because I think what you're talking about is a system that is so challenged, right? And in the language that I told you about, that I come from, I can't have a conversation with another doctor like that pediatrician without being able to say, hey, this is what you're treating here. And it's really challenging because I think exactly what you just said, this is all part of FASD, potentially. And when we start to parse out certain elements, it lets it become a bit more treatable and understandable by people who don't have that lens. That pediatrician or that family doctor, that nurse practitioner, they're so busy potentially seeing so many cases, sometimes it's helpful for them to understand, that's why you're on this medication, or you know, that's why this person is getting this treatment, because our whole system is based that way. If we had a more holistic system, I don't think we would need that, right? We'd be able to say, hey, this is Julie. Julie has challenges with impulsivity and attention. I don't care what that cause is or what title there is, but these are the treatments that they get. They get extra time at school, they get a computer to help them, they might take some medications to help with attention because we found that that is beneficial. Your role is this part, but we're not there yet. I don't know if we'll get there in my lifetime, I hope we will. But I've actually changed a lot of my assessments now to really just focus on the challenge here is mood, impulsivity, attention, substance, whatever else it is, and remain less focused on that title. Sorry, you're next.
It sounds like you're there, so that's good.
Well, it doesn't make much of a difference.
And then one other question, I just noticed on your slide that, for the first group of 25, that only 2 had been diagnosed with PTSD, which seems absurd to me for kids that are 15 were in care and they just said it was a care thing for trauma. And then in the post slide, 0 had PTSD. What's that about? How's that possible?
That's a very good question, and I think one of the challenges with a diagnosis of PTSD, and this has a lot to do with the assessment process. To get to that diagnosis, one often needs a really good understanding, and the child or the young person, for a diagnosis of PTSD in a youth, it's very different than an adult. And so the criteria are different, but sometimes you're not really seeing those symptoms come up because there's so much other stuff going on. So just like you just said, it's all alphabet soup, right? And I think you pointed out something really, really tremendous there, is that if we don't have a diagnosis, does it mean that they're not traumatized? Absolutely not, right? They haven't received trauma, it's just they're not presenting with nightmares or flashbacks or specific other symptoms. But that's not to say those symptoms don't exist. And when they're involved in such strong externalizing behaviors, let's say, obviously that could be because of trauma, but we don't have a title for that. We tend to call it like conduct disorder with trauma there. So, right there, yeah. So there is a diagnosis called complex PTSD. It's actually not recognized in the DSM-5, and so it gets you more. It's all alphabet soup, and it's mostly meant for people like me just to make ourselves sound really smart. Oh, one question there. Okay. Let me know when time is up. Thank you.
Hello.
Hello.
First of all, I'd like to say thank you for being here and giving your presentation. So when you were talking about your care plan with your clients and your patients, who do the referrals get sent to? Who does that after care plan? How many people are involved? And do you keep track of your patients, and what is the data for how many fall through the crack? Like how long do they stay in a care plan and then, maybe they vanish or whatever? Do you have the data for that data?
Oh, I wish I had answers to your questions. What I wish actually is that the people at CAS were seated here to answer that question, because I think that I will tell you, it was such a challenge to do this because we didn't get any funding for it. We just decided we're just doing this. It was actually received quite poorly by those community partners who had the 2-year wait list, and they were immediately saying, you can't do this, it's not valid, we're not seeing art. I'm like, well, actually at 10, I've done it, and now we know. And in child welfare in particular, it's so complex, right? It's so mind-boggling. Not only have I worked in child welfare, but I've gone through the adoption process with child welfare involved. My goodness, what a system. Talk about making something very challenging potentially. And so when you talk about who fell through the cracks, I imagine that once they're out of care, and this is what would happen, CES has no authority with which to find them, provide services, potentially. They can offer that and say, hey, this is important. But for some of those children returning to care or to other places, that can change a lot of what services they get. And that was why we did it, because we found that if we waited 2 years, the child could actually be out of services altogether, and we have no access. So if we do it right away, at least we can get something there and then educate people about it. We don't have any resources to be able to do that aftercare part, but what you just pointed out is so key. And I think that does need to happen for all these cases. And in fact, I think there really needs to be almost at least a province-wide and nationwide approach to this, to say, these children who meet this criteria, how quickly can we get their diagnosis criteria met if that's what we need to do? but more so where do the resources get aligned to their area of need? If we do it for autism, why can't we do it for FASD, right? And I'm not saying it's well done in autism at all, it's not. But why can't we do something for FASD? And then in that context, also look at who's falling through the cracks and why, and how do we ensure that doesn't happen? So how do we follow you to make sure that you get to being that successful adult? And that's where that idea of even a tool to help identify what needs to be looked at, what domains of development, those 8 areas, need to be looked at to make sure it happens. There's a few hands.
Hi.
Hi. Okay, I'll just go wherever the voice comes from.
As a person who was diagnosed at 15 with ADHD, but prior to that was just a kid needing discipline and a kid that was bad and and so forth. But my thing is with the ADHD, the characteristics of ADHD and FASD, which my mother was a little saint Italian who never drank a day in her life, so now I want to go back to her and say, hey, did you? But the characteristics overlap so much. Now, fast forward, I worked at special needs for 23 years in our school system. A lot of it is being labeled. If you have a label, you get help. And that's the sad thing. And so we were autism, I could be a total expert on autism. But then the spectrum came in, being on the spectrum. We're all on the spectrum. But FASD should be in that spectrum because it touches on every one of these characteristics.
You're bringing up a really excellent point around what neurodevelopmental disorders really are. And if we're thinking about this from a more systems level, right? Like, why get a diagnosis? It's not just an academic thing. I'll be offensive and maybe I won't. The challenge is that we have these people who are so focused on title and on alphabet soup and on this criteria versus that criteria, which I can understand in certain uses. When it comes down to the actual ground level, what is that doing for the person? There is an argument that says, let's not focus on what the title is, let's focus on what the area of need is. So how do we look at what this youth needs? If you're a troubled child that's being labeled a problem maker and clearly your challenges with attention and focus, let's just say, okay, so there's a challenge with attention and focus. There might be these underlying neurodevelopmental reasons for that, but I don't want to bring all of our attention to coming up with what is what and what's the title. Let's focus more on what's the intervention. So what does that school need to do? Is there a role for medications? Is there not? And even if there is, you can't just put a kid on medications and leave them like that forever. That's the other thing that tends to happen, right? I see kids who are like, been on the same medication for 16 years, and then they're like, wait, no one told me that I should be changing this, or this might not be needed anymore. So I yes. Yeah. That's right. And I think this is because, again, back to that language challenge, right? We come from different worlds, and I think even the education world is speaking a different language and trying to get caught up, and they won't do anything unless they have that. Okay. All right, another question. Hello?
Hi. I was just wondering, I noticed that you did bring up the fact that a lot of children, especially ASD, there's a prevalence of them coping with their situations with marijuana use. I'm just wondering, have you noticed in your professional opinion, because I feel like just from personal opinion for myself, I've just noticed from doing research myself, there's not a lot of prevalence in what happens when mothers are smoking weed and what happens to that fetus in return. Have you just noticed, like, in your professional opinion, any differences in that, where like if a mother tells you like, oh no, I smoked a lot of marijuana during this use, and then you're like, oh, like just trying to see that prevalence between the two in a way, because they both affect and alter the mind and also affect the development of issues, right? So.
Yeah, it's a great question. So thank you for that. back to that alcohol being so small, the chemical of alcohol, and really causing damage to brain stuff and brain function. We know cannabis is a bigger particle, and it doesn't get through that barrier as readily. That being said, it is associated with some challenges. It is associated with learning disabilities. I'd have to go back to all the data that they have and look at the studies, but what I understand, the other challenges is that not everyone who is smoking weed will potentially also be drinking alcohol at the same time. But there can be the duality there where they're using both at the same time, and that's where there's a challenge as well. Some doctors have gone to the extent of saying, look, just don't want you to do alcohol because we know it gets into the brain, so can we replace that with something else like cannabis? And I can see why that would be something that they would think about. You can understand why. And if that is what works for that mother, so be it, right? It's something that works. And there can be fewer challenges down the road with cannabis abuse. Or cannabis use, I should call it, because it's legal. But yes, there are some challenges there. Thank you for the question. Yes, in green.
Is it going to work? This is scary. So we work in mental health, specifically in education. And I was just wondering, and if anybody is in the room that does this work specifically, but I was just curious around psychotherapies and modalities that you think are really important when working with kids with FASD. And I ask that because I know that a lot of the therapy relationship depends on the child, on their needs, it's relational. Shannon talked about things like mindfulness and meditation, the polyvagal stuff, art-based therapies. We do a lot of land-based stuff. But if there's anything that you would recommend, I don't think we have a lot of psychotherapists in the community that are working specifically in the area of FASD. And I think aside from having a really good knowledge of FASD, is there anything that you would recommend?
Yeah. Thank you for the question. It's so important to talk about this. And when we think about that 4% number, it's time to get more psychotherapists that are trained in this area. And I think one of the biggest areas of training is patience. And that ability to remain patient, to understand that everything you just discussed one day, you'll think, okay, we got here, and they have these new skills, now I'm definitely going to use it, and when I see them again, I just go to part 2 of that. That's not the case with FASD. You have to be prepared to go back to phase 1, go back to phase 1, and walk them through again. It might get faster each time of going back to phase 1 and walking through, but you have to do that. That confabulation element also has to be taken into consideration. Confabulation is really defined by that ability to come across as though you know what someone's saying, and you're just going to come up, just make them think that you get everything that they're saying, everything's fine. But the truth is, you're not following the conversation at all. And that happens a lot in psychotherapy. So I've seen psychotherapists that are like, but I talked to that kid for an hour, 2 hours, and I've been doing this for 7 weeks. And it turns out, everything they told me wasn't real, or everything we talked about, they couldn't even apply it. And that has a lot to do with that inability to understand the needs of that individual. So meeting them where they're at is one thing, and really recognizing that FASD is this massive spectrum, right? And so, again, kids and young people will present differently, even adults will present differently with different needs. So you can't apply the same lens to all, but to be very patient. Yes, hi. Uh-oh.
I don't know why there's an uh-oh. What are your thoughts on the development of a psychotropic medication algorithm for pediatrics? We have one for adults, but particularly that psychotropic medication in children and youth is all off-label.
Oh, yeah, see how I said very complex question, an algorithm for psychotropic medications in FASD. It's a very good question. So what this refers to is, why is it that you'll have a doctor like me write all these medications for a child, and when you Google it, it's like, wait, I can't give this. It says, don't give this to a child. It's considered dangerous. They're like, wait, look at this guy. Does he actually have a license? And I recommend you all look it up, but yeah, hopefully you do. So the reason why we don't is because everything is black box when it comes to these medications. Not everything, but oftentimes it is. The way drug companies work, they're not focused on young people for the most part. The medications tend to be developed primarily for adults. That's where their funding lies, that's where their market is. And so we then come in and say, hey, we think this works well for kids, but if we change the doses, could we do this? And we might get some studies for it, but the drug companies never want to say this is what it was intended to do or why it was produced. Sometimes they do for some medications where there's a market, but oftentimes that's not the case. But then why don't we just have a clear, this is the dose you should go with if this, and this. The reason being is that back to this being a spectrum, back to the brain being very different in different youth and young people, that's where I think there's a challenge. Some 14-year-old will present as a 14-year-old, some are like 18-year-olds, some are 7-year-olds. And how their brain develops and how that brain is impacted by different medications will be so different. So that's why I think there's challenges coming up with a specific algorithm. That being said, there are algorithms for things like ADHD. We can apply those to FASD, or youth with FASD. What I find though is that oftentimes it's ineffective because you're treating a brain that has developed in a different way than what those recommendations were based on. That was done for the general population. It wasn't a specific FASD with ADHD treatment algorithm. Could that be done in the future? Why not? I think it could be.
What about applying as you can the adult autism?
Absolutely, and I think that's where having trained practitioners understand that and be able to do that is really key. And so I'm program director now of a new program of psychiatry, the newest one in Canada, that is going to open in the Brampton region, the TNU. And this is something that I look forward to making sure all the residents are trained in, because I think we really do need this for the future. Another question?
Just right in my hometown. I had a question about, obviously Toronto is a big epicenter of research and technology and all these wonderful things. But staying at Brampton's my hometown, I now work in Canada Story Point, which is pretty rural, South Ontario. And knowing that a lot of great things come out of Toronto, just kind of wondering when we could maybe see some of this research and stuff come out to, obviously a lot of people here, probably from more rural regions where this research is not getting to those people who sort of need it, right? I know great things take time. But I'm not going to ask you for a timeline because that's probably not something that you're able to answer. Are there any recommendations or strategies for people who are trying to, bring this information to their communities or to people who are just kind of getting comfortable with the idea that FASD is actually a thing, or unpacking the stigma surrounding it, or tackling things like the police services in those areas? I have so many questions, I'm glad you wrote your email down. But when is that sort of going to be distributed amongst like doctors or professionals and stuff?
Wow, I wish I had the answers. Yeah, what I would say is I think to get to those answers, it starts in places like this, where there can be that organization around advocacy. How do you bring that voice forward, and how do you make sure that it's heard, and how do you demand change for this group? And I think that the ability to move science into public discourse is that element of advocacy and having initiatives set up. RJ, for instance, will, I'm sure, tell you about certain initiatives involving red shoes, which is lovely. And so these kinds of initiatives are so important, and I think it's what follows from that to say, why don't we have these questions answered, right? If we're saying it's less than 4%, why don't we have a task force set up? If we're willing to announce a czar for fentanyl, is that what just got announced? My goodness, what is that, like 0.1% or 0.01? but we don't have, I don't know of a specific legislative body or someone that kind of has that role within government. So I think these are the questions that need to be asked. I also know that we're in the midst of an election, so I leave it all to you. All right. I might be out of time because I think you're all due for a break. Thank you.
I want to say thank you for your time, and I also want to say that many conferences we've had the psychiatrists come up and speak, and I can say on behalf of our friends here who also have FASD like myself, it can come out very negative and very blaming of the individual, making it look more like it's a behavioral-based kind of thing, and you have to change the behavior. And then also many times we're spoken about, not spoken to. So I just want to say that I really, really appreciate the way that you presented. Your openness, honesty, information-based, but also not scary, shaming, blaming kind of stuff. And so I think it's great to have somebody that is in that medical field that I could say we can feel like we could actually talk to you and have those relationships. So I want to really say thank you to you for that. You can't see me, it's not a horse. All right, so before we go to our break, is that another ticket from Jyoti? Do the same. All right, so our first number here is, last three numbers are 493. 493. Are 505. 505. Okay. Next one is 492. 492. So lucky half of the audience, I guess. All right. 506. 506. No, Joji. 506? All right. Over here. All right, here we go. Okay, ready? I'm mixing them up here, shuffling. Some people need to be shuffled, so here we go. All right, last three numbers are 519. 519.
There'll be more sweaters, so you just gotta stay.
Oh, there'll be more sweaters, more gift prizes, more excitement to come. After the break, we are very fortunate. We will have a panel of individuals who will be sharing some great information and doing a little bit of Q&A on the panel here. So, super exciting. And then we got another keynote after that. And then I think we're So, exciting times to come. Yes. You have to have a horse out
Hey, good morning, everybody. I'm Steph, the Healthy Babies manager. Tomorrow morning, we're having a Healthy Babies session. I know I haven't seen everybody to tell you, but tomorrow morning we're doing a Healthy Babies session in that room back there at 8 to 9, breakfast and starting at 9. If there's any CWW workers here that would like to join us, you're more than welcome, or any other Healthy Babies, just let me know, and we can come back there. We'd be happy to have you. All right?
8:30 we start?
9 o'clock we start.
Breakfast is at 8:30.
8 to 9. Oh my lord. Please come join and help me, okay? So I just wanted to let you know because I know I have new workers here that I have not met yet, so I just want to let you guys know, inform you, and some have to leave early, which is unfortunate, but just hope to see you there. Okay, thanks.
I'll be there.
So if you have a healthy baby, I guess you just drop them off there tomorrow? Is that what it is? Okay. They're not healthy, they don't smoke them? Okay, so feel free, go get a snack, get some coffee, dance, whatever you want to do. Stretch. All right, thank you.